Yeah, 1 second only. Sure. First, I'm sorry, but I'm unable to speak Greek, and it's really a shame because I know that many of you speak perfect French. So anyway, I'm very pleased to participate in this meeting, and I thank the Hellenic Association for the Study of Liver Diseases, especially George, for inviting me. So here are my disclosures. And as we all know, UDCA is current treatment for PBC, because UDCA not only improves liver tests, but also decreases the rate of clinical events, and as a result, it's recommended for every PBC patient with abnormal liver test, regardless of histological stage. But UDCA doesn't work in all patients, and roughly 30 to 40% of patients have an inadequate biochemical response to UDCA and need novel therapies. So what are the potential targets for new interventions? And regarding the pathogenesis of PBC, of course, the first step is bile duct injury, mainly due to inflammation or immune attack, leading to cholestasis, with further enhancement of bile duct injury and leading to the final common way of fibrosis and cirrhosis. It's common, of course, to all chronic liver diseases without any effective drug at this time. So novel approaches focus mainly on cholestasis and are derived from major input into bile acid physiology during the last decade. And in addition, a number of these new agents have also anti-inflammatory and anti-fibrotic effects. And because of strong interaction with glucose and lipid metabolism, they are also studied in NASH. So don't be afraid when looking at targeting cholestasis with the goal to decrease hepatic bile acid load. So it's just a very quiet hepatocyte, but is to convince you that the nuclear receptor FXR, just in the center, is a major player in bile acid regulation, because its activation is able to increase biliary secretion, increase bile acid export, decrease bile acid synthesis, and bile acid uptake. And that there are also other nuclear receptors playing a role in this complex network, namely PPAR, PXR, and the glucocorticoid receptor, GR. But there are also players outside the liver regarding cholestasis, because, of course, bile acids are reabsorbed in the ileums through a specific transporter, ASBT, and in the intestine cell, bile acids bind to, again, FXR that is also present in the intestinal cell, and that leads to activation of HGF-19 that is released into the portal blood, taken up by the liver, and finally in the hepatocytes is also able to inhibit bile acid synthesis. So it's another way to inhibit bile acid synthesis in addition to the classical way, bile acids and FXR binding. So as a result, inhibitors of ASBT and FGF19 are of potential interest in treating cholestasis, and a number of these agents are under investigation. And finally, of course, microbiome plays a role in bile acids metabolism, and its manipulation is another point for consideration. But today, I'm talking about the agents with the most advanced clinical evaluation, namely budesonide, obeticholic acids, FXR agonists, and fibrates that are PPAR agonists. So let's start with budesonide. The rationale for steroids in PBC is well established. Of course, PBC is a chronic inflammatory disease, and there is a continual and sometimes true association with autoimmune hepatitis, but Ansgar will address this complex issue in the next talk. It has been shown that transaminases in lymphocytic interface hepatitis have been identified as prognostic markers. Steroids are able to stimulate biliary secretion. And lastly, in PBC patients, 2 decades ago, steroids have been shown to improve liver test and histology, but with an increased bone loss. So why prefer budesonide in PBC? So PBC is mostly a non-systemic autoimmune disease. It's a high-risk condition for osteoporosis, and budesonide has a high hepatic first-pass metabolism, leading to an increased liver concentration and limited systemic side effects in the absence of cirrhosis. In addition, it has a greater affinity for the glucocorticoid receptor, and is also a PXR agonist with ability to increase biliary secretion. So here is the summary of the studies, available studies as add-on to UDCA, and note that there are rather small studies with dosage ranging from 6 to 9 milligram per day, and duration from 1 year to 3 years. And only one study was double-blind randomized. And here are the results. So green means good, roughly good results. And as you can see, in the majority of studies, there was a beneficial effect on liver test and even on histology without increased bone loss. And this is just to illustrate this finding in this study. As you can see, addition of budesonide to UDCA makes better than UDCA alone in terms of ARP and histology, especially the fibrosis score. But this is only small or open studies. So before to be able to draw firm conclusion, we are looking forward to the results of a large phase 3 studies, and results are expected by the end of the year. So, and now let's move to the new star, obeticholic acid. So it's a first-in-class FXR agonist. It looks great, really. And it's a derivative of the natural quinodeoxycholic acid, that is the natural agonist of FXR, but is 100 times more potent than quinodeoxycholic acid. something. Oh, sorry. So generally speaking, FXR agonists look like really a magic bullet, because beside their effect on cholestasis and glucose and lipid metabolism, they act also again inflammation, fibrosis, portal hypertension, cellular proliferation. And in addition, they have also some immunosuppressive effect in some experimental models of autoimmune diseases. So what are the results in the patient? Because the previous slides, it's mainly based on experimental data. In the patients, so in this phase 2 study, in patients with inadequate response to UDCA, OCA was able to decrease ALK force on average minus 25% when compared with placebo, and this effect was maintained at 12 months. But the main results are given by the POISE study. So it's a large phase 3 study with more than 200 patients in patients with inadequate response to UDCA. It was a double-blind placebo control with 3 groups: OCA 5 to 10 milligram a day, OCA 10 milligram a day, and placebo. And the primary endpoint was only biology, so it's ALK force less than 1.77 the per limit of normal, and normal bilirubin. And here are the main results. So as you can see, the primary endpoint was reached more often in the treated group, so in color, when compared with the placebo, roughly 50% of patients. And the response of alkaline phosphatase was rapid and maintained throughout the study. And after the 12 months double-blind period, all patients were given OCA 5 milligram a day, and then increased to 5 to 10 milligram a day at 3 months. And note that the efficacy was similar in the patients treated initially with placebo, with no difference at the end of the study. So it looks great, but there is a very frequent side effect. That's pruritus, with 2/3 of patients suffering from pruritus in the treated group versus 1/3 in the placebo group. And mechanism of induced pruritus are far from clear. There is no increase in autotaxin levels, but it's clear that it's dose dependent. The severity is dose dependent, as shown here. And the recommendation is to start at low dose, 5 milligram a day, and to increase at 6 months if needed, depending on the efficacy and the tolerance. Nevertheless, OCA got a provisional approval last year from FDA and now the European too, either in combination with UDCA in adults with an inadequate response to UDCA, or as a single therapy in adults unable to tolerate UDCA, but in my experience, it's very rare. But we have to keep in mind that the long-term efficacy and safety have yet to be demonstrated. So after this brand new drug, very old one, fibrates, so how could it work in cholestasis? So they are agonists of PPAR with anti-inflammatory action. they can reduce bile acid synthesis, and they improve some canalicular transporters. Of course, all these actions are beneficial when treating cholestasis. And we know from a long time, with numerous pilot studies, mainly from Japan, but also from Europe and the US, that there is a clear beneficial effect of either bezafibrate or fenofibrate when added to UDCA. And in addition, pruritus decreases in the vast majority of patients, as shown in this Spanish study. But again, it was only a pilot study, and phase 3 trial, large phase 3 trial, was eagerly awaited. And this time has come because last month at the EASL meeting, the result of the French, so I'm very proud of that, the French multi-center double-blind randomized placebo-controlled trial of bezafibrate 400 milligram a day in combination UDCA were presented, and it's a Bezoso trial. So here is a flow chart of this study. So 100 patients with inadequate response, biochemical response to UDCA as defined by Paris 2 criteria, and that half of the patients had advanced stage. So 50 were randomized with placebo and 50 with bezafibrate, and of course all patients at continuous UDCA. And the primary endpoint was rather tough because it was defined by a complete biochemical response at month 24. That means normal bilirubin and normal LP and normal transaminases, albumin, and of course prothrombin time. And here is the main results, the primary endpoint, and as you can see, 30 patients in the treated group reached the primary endpoint, so at complete biochemical response versus none in the placebo. And in the same way, 2/3 of patients normalized alphos in the treated group versus none again in the placebo group. All liver tests were significantly improved, and the frequency of adverse events was similar in the two groups. And in addition, regarding each score, it decreased in the fibrate group. There is no change in the placebo group. And finally, in terms of fibrosis markers such as FibroScan and the ELF score, there was also a significant decrease when compared with placebo. So, of course, this strongly supports fibrates as an effective add-on therapy. And my last slide is this one, because I mentioned the potential interest of inhibitor of ASBT. And last month, a study on the pruritus in PBC was published. And as you can see, this drug was able to improve significantly pruritus when compared with placebo. But not surprisingly, there was a common side effect, diarrhea, in about 1/3 of patients, and that might limit its use in the long term. So to conclude, I think we have, of course, to keep in mind that UDCA is still the first-line therapy for all patients with PBC. But in patients with inadequate response to UDCA, there are now additional options. One is approved, that's obeticholic acid. Other are still off-label at this time. Maybe it will change soon. First, fibrates, with I think very impressive results of the bezafibrate trial, and budesonide with pending results of large trials. But their respective place as add-on therapy to UDCA have yet to be determined. And finally, there are also new anticholestatic agents under evaluation, PPAR gamma agonists and FGF19 analogs. So promising times for patients with PBC seem likely in the near future. So thank you for your attention.